I would like to speak about an 11-month-old child, cyanotic, 9 kilos, saturation was 77%, dependent on chronic oxygen substitution. The diagnosed cardiac one was double outlet right ventricle, Fallow-type with the interrupted inferior vena cava, and he had been corrected at the age of 5 months. So now he was 6 months later in clinical signs of high output heart failure. Here you see the pulmonary angiogram. You see that we had to go through the interrupted vena cava inferior, and you see an enlarged heart, and you see severe intrapulmonic shunts. QP to QS was 0.4 to 1 with a right to left shunt of 56% with normal pulmonary arterial pressures. So actually we didn't really know what was happening, and our pediatric university clinic people did this because we always only looked at the heart. They looked at the abdomen, and when they did the CT, they found this abnormality, which is called Abenaki Malformation. For me, it was the first time to come across this. And the Abenaki Malformation was first described by John Abenaki in the year 1793. It's a congenital portosystemic shunt with absent or hypoplastic portal vein and a congenital mesenterico-caval shunt. The portal venous blood flow is directed directly to the vena cava by passing the liver, and a hepatopulmonary syndrome is present, and cyanosis is due to progressive development of intrapulmonary right to left shunt. So after we understood this, we went from the jugular vein, we went into this splanchnic vessel, which you see here, and the next thing was we did a test occlusion with a 12 millimeter Tyshek balloon, which showed us you see here the portal vein, and we also with the second catheter measured the venous pressure during hepatic venous wedge pressure to see whether it did not rise, which it didn't. So we thought it was safe to occlude it, and we were very happy that we have this new MFO occluder available, which has the advantage it can be delivered through a small sheath with a big diameter. We chose the MFO 1410, and here you see how it is positioned. We chose a 6 French Terumo braided sheath from the right jugular vein, and here you see how we put the occluder in place. And after letting go of it, you see that the renal vein here is still open, and total occlusion was achieved. So in conclusion on this case, Abenaki malformation must be considered in patients with hepatopulmonary syndrome developing progradient cyanosis. After diagnosis, test occlusion should be performed to assess if an occlusion is tolerated, so if the portal pressure is not going up. In the current patient, the abnormal venous vessel was successfully closed with a Kona VSD occluder, and I just talked to the mother. We are now 7 months behind. She says she has a completely different child. The child is not cyanotic anymore, is not in heart failure, and thriving really well. So it was a very good clinical result. The next patient I'm going to talk about is a 15-year-old boy with a severe coronary fistula. It's not a loud systolic, but a loud systolic, diastolic murmur that the patient had. And here you see the large fistula that had a diameter of even 16 millimeters. If you look here, it was 16 millimeters here, but at the end there was 5 millimeters. We chose to place a Kona occluder, which can be delivered through a 6 French coronary guide. In this case, we took a 10-8, and we achieved complete occlusion of the defect. Sorry. What I would like to stress here is, if you see the nutritioned coronaries, they come here. So after 3 months, we did a CT scan that showed that it was still completely occluded, but there's a thrombus formation here, and we had put the patient on warfarin, and maybe he will need it lifelong. Thank you very much.
Any question? Thank you for very excellent cases. My first question about the portohepatic fistula. What is your problem after the closure of the portohepatic fistula? In some patients, is if you have a small portal vein, it's possible patient go to portal hypertension symptom. For example, hypersplenism, hepatomegaly, ascites, and rising of the liver enzyme test. Do you have any problem after the closure of the portohepatic fistula in this patient? Because the portal size of the portal vein seems to be not very large. It seems to be small.
I agree with you, but I have to admit that I'm not an expert on this. This was my first case that I treated, but what we did was we did a test occlusion, and we had another catheter in a wedge position in the hepatic, and there was no change in pressure after we test occluded. So we felt safe to do this. But I talked to other people who have done more patients like this, and sometimes they say, well, this is region surgical, that you can just ligate or band the vessel and not occlude it completely. So this is what some people suggest. But in our case, since test occlusion did not change the wedge pressure, we felt safe to close it completely. But I think you're absolutely right. You have to, well, there's different forms of Abenaki syndrome also, and it can be very hypoplastic, and some you cannot close like this. I agree with that.
But measurement of the portal wedge pressure after the balloon occlusion test is better to do by the technique of not millimeter mercury, but millimeter of the H2O. In some patients, while the balloon occlusion test, you have a high millimeter H2O pressure, near higher than 20 millimeter H2O. It's very important for us because measurement of the wedge pressure, portal vein wedge pressure, before the complete closure of the portohepatic fistula is very important. In our experience, in our first case, we have a problem like this. We have a significant thrombosis in the portal vein, and we use antithrombotic drugs. And finally, after near 1 or 2 months later, we have a very good result after using the antithrombotic drugs for desorption of the clot inside of the portal vein. It's our experience in our center.
Thank you for your comment. Thank you.
I have one question. Did you use the balloon only for hemodynamic or for measurement?
Well, the question was whether we used the balloon for hemodynamic measurements. Well, we test occluded the splanchnic vein, and we measured with a wedge the portal venous pressure at the same time. Well, we wanted to do, firstly we wanted to depict the portal system better. This is why we gave a contrast through the balloon catheter, and we had a second catheter in a portal wedge position.
You mentioned you used the MFO 1410?
Yes.
You mean 1412?
No, it was 1410, I think. Maybe 1412, yeah.